We are live.
Okay, great.
Amit,
Hi, Dr. Base. Hi.
Dr. Lalan कैसे हैं?
बढ़िया बढ़िया.
Good
Good
evening,
evening,
sir.
everybody. हम देवरुण राजेश को एक बार फोन कर लो आप. जस्ट फोन राजेश.
नहीं अभी बस ऐसा समय तो उससे में अभी तक खोल नहीं है। एक अब तो अजय खींच के खींच करके इधर बिग बैंग खोलो क्या था। Should we start, sir?
Yes, please go ahead.
So a very good evening to everyone and welcome to this session by the National Neonatology Forum. Today's topic is inborn errors of metabolism in neonatology, a practical case-based approach. This is a part of the genetic and rare disorder series, Decoding Newborn Genetics Episode 2. Now, why this topic is important? Inborn errors of metabolism are individually rare, but collectively they are significant. They often present with non-specific symptoms in neonates, making early diagnosis challenging. However, a timely recognition can be life-saving and outcome-changing. With expanding newborn screening and genetic diagnostics, awareness is more important than ever. Practical case-based understanding helps us to bridge the gap between theory and bedside management. Now, I request respected Dr. Lalan Bharti, sir, to kindly give his views on the topic. Over to you, sir.
Thank you, Dr. Nile. Good evening, everybody. It gives me great pleasure to welcome you all to this important session under the Genetic Rare Disorder series, Decoding Newborn Genetics. So, as Nile was telling, the today's topic, inborn error of metabolism in neonatology, is extremely relevant to our day-to-day practice, where early diagnosis can truly save the life. We are privileged to have with us esteemed special guest, Dr. Madhulika ma'am, along with our speaker, Dr. Hasina, who will guide us through the practical case-based approach. I also thank our moderator, Dr. Rajesh and Dr. Mayank for facilitating this academic exchange. I'm sure this session will be highly insightful and clinically useful for all of us. So thank you for giving me this opportunity. Let's begin the session.
Thank you, sir. Dr. Amit Upadhyay, sir, would you like to share your views? I think sir is on airport. He is boarding a flight. Dr. Devarun, can you please show the CV slides? So basically today's session will be on the recognition approach and management strategies. I also encourage the participants to actively engage and share questions during the discussion. Now, without further delay, I invite our esteemed guest for the session today. Madam doesn't need any introduction. We all know the immense contribution of ma'am to rare disorders and genetics and even metabolic disorders. Dr. Madhulika Kabra ma'am is emeritus scientist in ICMR New Delhi. Formerly, she was the professor and head at the Department of Pediatrics and in charge of Division of Genetics at AIIMS New Delhi. Madam has lot of awards, like she was also awarded the Dr. IC Verma Lifetime Achievement Award, then Dr. IC Verma SIMG Outstanding Scientist Award, and you can yeah, and Madam was also the head of the Division of Genetics, and Madam has collaborated in a number of research projects, and Madam has more than 450 research publications. Over to you, ma'am. We welcome again to you for participating in this webinar, and we would like to hear your views on this topic.
So thank you very much, Mayank. Thank you very much, the NNF team, Amit, everyone, for inviting me here. So very important and relevant topic. We have been discussing about this for a very long time because the diagnoses were very frequently missed earlier and the children and babies used to succumb. I would just like to say two things which are very relevant at this point in time in the present era. One thing is that you must have all heard that now Delhi government has declared the newborn screening program, which is called Anmol now. Dr. Seema is leading that, and there it has been the tender mass has been included in the screening. So around 50 disorders will be screened. So this is one important thing. We'll be getting babies who will be identified. And the second important thing is that now we have means to treat them under the rare disease policy. So all small molecule diseases where specific diets are required, they can be provided through the National Rare Disease Policy Fund. So for pediatricians, for neonatologists, I think it's extremely important that we make a timely diagnosis because we now have means of treating these patients. Earlier, we were thinking that we have nothing to, I mean, we can do emergency management, but after that, the diets and other things were not easily available. So now it is available by the government because in the 50 lakh rupees, which is the limit for rare disease patients, we can continue these babies on specific diets for years together. So these are two important things which all the more increase the importance of identifying and diagnosing these babies earlier. So very relevant and very important for all pediatricians and neonatologists. So we can go ahead and listen to Hasina, what she has to tell us.
Yes, we can go to the speaker. Can you introduce the speaker, Dr. Nilay?
No, sir. We are going to introduce her. Dr. Devarun, please change the slide. Yeah, sir. Would you like to introduce Dr. Hasina? Dear Amit, sir.
So, good evening, everybody. And it's a pleasure to have Dr. Hasina Madam over here from SGPGI Lucknow. And she is MD Pediatrics from MAMC and DM Medical Genetics from SGPGI. And she is Member Secretary, Center of Excellence for Rare Disorders at SGPGI. She has won numerous awards along with the Best Paper, Research Paper Award for 2 consecutive years in 2024 and 25 at SGPGI. So it's really, she's a very academic person and we are all very happy to have her. Over to you, Dr. Hasina Madam, to begin the lecture.
Yes, sir. Thank you very much, sir. So I'll just share my screen. Is my screen visible?
Yeah, it's visible.
So I'll just slide. Okay, so good evening, everyone. At the outset, I would like to thank the organizers and National Neonatology Forum for giving me this opportunity to share my little bit of experiences in one of my favorite topic, inborn errors of metabolism. So during my post-graduation period, we hardly considered IEMs as one of the differentials, or maybe it will be down the table. But then because we thought that those disorders are really rare and complex and in fact quite intimidating. So here I'm not going to take you through list of 1,000 disorders. So what we have to really know is to understand, to recognize the pattern. So that's all is needed. So here in this talk, we'll think as clinicians, we will see how case-based approaches and what maximum we can do at the bedside. So that is the main theme of this particular presentation. And by the end, I hope that I would make this as a very easy and not a very confusing topic per se. So without any further delay, I'll just start this particular session. So the definition, why it's important. Of course, we have to know the basics about inborn errors of metabolisms. I'll take you through a little bit about the basics and then we go through the case series. So initially, traditionally, the inborn errors of metabolism were very narrow. It was more lab driven. It was like one gene, one enzyme hypothesis. And any disorder where there should be a measurable biochemical abnormality. So that was considered as inborn errors of metabolism or inherited metabolic disorders. But then now it has really, with advancements of sequencing technologies, metabolomics, and a lot of advancements, there is a change in this particular definition. So now it is considered that any condition where there is a disruption of a metabolic pathway, irrespective of abnormalities are there in the biochemical laboratory test or not, is considered as inborn errors of metabolism. So this is a recent classification by Ferreira Group, nosology, and where they have classified around 1,000 inborn errors of metabolism across 130 groups. And amongst these 1,000, 25% of these disorders, they present in the neonatal period. And so these are the major categories or subgroups of these inborn errors of metabolism. But then why we really have to know about them? Though we say it is rare, I would say it is under-recognized because the global birth prevalence of all IEMs, it's around 51 per 1 lakh live birth. And especially in countries, India and low middle income countries, the case fatality is almost 1/3. And most important is how we can reduce this case fatality is because 18% of these inborn errors of metabolism are treatable. There are some form of treatment available for them. And majority of these treatable IEMs comes under fatty acid or ketone body metabolism or vitamin and cofactor metabolism, etc. And though the pathophysiology is quite complex, so from clinical point of view, I'll just keep it very simple. So this is a very, very simplified diagram where we can see that an enzyme is nothing but a protein which acts as a catalyst, which helps in the conversion of a product, a substrate A to a product B. But then enzyme per se is inactive, but then we require something called as a cofactor, which will help in the activation of enzyme so that such conversion takes place. And all these metabolic process, we know that's not happen in a single cell. So it happens in a lot of organelles. It happens, the molecules cross through cell membranes. So transporters equally play a very important role in transporting the substances for subsequent conversion. So whenever there is an error, whenever there is a genetic defect causing subsequent enzyme deficiency or cofactor deficiency, there'll be accumulation of substrate. And this accumulation in turn can result in these accumulation of toxic products. So they will cause intoxication symptoms. Sometimes we have this toxic intermediates. And when the final product is not produced, then we know that symptoms of energy deficiency can result. I know the pathophysiology is even quite complex, but then from clinical point of view and for the common disorders we see, this much is enough for us to understand about the basics. And the clinical presentation is quite varied, but we see a major chunk in the neonatal period. Sometimes they have even antenatal presentation. And we do have symptoms which can be acute catastrophic or chronic progressive. Sometimes they even present during the adolescent or adult period, or they just can involve specific organ system. So they can present, in fact, to all medical specialties. And in this current newborn era, we also face another newborn screening era. We face another important challenge where we find abnormalities or in the metabolites in an asymptomatic newborn. So, and why this happens is basically because even the same disorder can present in varied age group. That is because of the residual enzyme activity and also because of the triggers and other environmental diet factors or other modifying factors like epigenetics, etc. So before moving to the main part, so it's important to know, again, this is a very busy slide, but then I'll take you through the most important points. So initially, the classification was like intoxication, symptoms related to intoxication, symptoms related to energy to affect complex disorders. But now there has been a shift in the classification, because the previous classification was more clinical oriented, but this classification blends clinical as well as pathophysiological mechanisms. So we have small molecule disorders, complex molecules, and energy defects. So small molecule disorders, on one hand, we have the accumulation disorders, that is the toxic product accumulation due to enzyme deficiencies. And this includes amino acid disorders, urea cycle, organic acidureas, etc. And I will concentrate more on this group in the talk today, because most of these present, majority of these present in the newborn period, and most of them are treatable. And the classic findings which we can see in these group of disorders is there will always be a symptom-free interval, and then this will be followed by an acute onset of illness. So which means that the embryo or fetal development is usually normal. And apart from acute or intermittent presentation, few of them can also have a chronic or progressive symptoms, and most of them have a trigger in the form of fasting or illness, some febrile illness, etc. Deficiency disorders, like metal deficiencies or some deficiencies of essential, non-essential amino acids, these more or less behave like complex molecules. So in the complex molecules, we can see this is a table. So these are the complex molecules. And complex molecules per se means they are large molecular weight, and which are not water soluble, and which do not diffuse across the cell membrane. So here we do have, again, divided into accumulation disorders, and all your major storage disorders comes under this. And they generally have multi-system presentation, and they can also have antenatal signs, but it is important to recognize them because there are emerging therapies for them, and few are already approved. And in the deficiency disorders, it is more like your peroxisomal disorders and cholesterol bile defects, but majority of them are multisystemic and they are not treatable. And then this new group is the cell processing and trafficking defects. But again, these more or less mimic like the storage disorders, and they are also multisystemic. In energy defects, it is again divided into membrane carrier. There is an abnormality in the transporters, and they are treatable to some extent. Then we have cytoplasmic energy defects, which includes all your glycogenolysis, gluconeogenetic defects, etc. And then mitochondrial disorders, which includes all the respiratory chain disorders and electron transport chain defects, etc. And few of them are treatable. So, but then the talk today will more concentrate on these intoxication symptoms, because they are the ones who present acutely and are manageable. So I'll just take you through this case scenario where you always come across such a situation. A 5-day-old neonate who's born of second with for of a consanguineous marriage. Then we have sometimes history that first child expired and the cause is really not known. This kid was relatively doing well in the initial 2-3 days, and then suddenly started having poor feeding, lethargy, coma, and then finally succumbing. But then this is how we characteristically try to explain when you have to suspect an inborn error of metabolism. But then before going to that, we really have to know why neonates are very vulnerable. So one reason is once they're inside the womb, they generally get the nourishment and as well as detoxification. Everything happens through placenta. So the mother safeguards the child. But once the child is born, so there is a rapid shift. Suddenly they have to rely on their own enzymes, their own system for energy or for detoxification. And another reason is immature organ system. So one is their majority of their organs are very high energy demanding organs, but their physiological reserves are relatively low, and the detoxification systems are relatively immature. So as a result of which, even under minor stress, they won't be able to handle such need, and they might result, especially when there is energy deficiency, accumulation of toxic materials, their immature organ systems cannot handle that. and relatively non-specific symptoms, because neonates, they have very limited responses to illnesses, be it sepsis, be it asphyxia, or drug intoxication, or what, or even IEM for that matter. More or less, they all present with non-specific symptoms like feeding difficulty, vomiting, lethargy, coma, etc. And so it's quite difficult for us to really pinpoint and suspect an IEM. And of course, increased risk factors, especially even with minor illnesses or physiological stress, newborns will not be able to tolerate. So it's because of this reason the neonates are more vulnerable to inborn errors of metabolism. So when do we really have to suspect an IEM, an acute IEM in a sick child is like the first scenario I told you. A child is relatively well for 2-3 days and then has a sudden rapid deterioration. So the reason is initial 2-3 days the child gets guarded from the reserves from the mother, and then once feeding starts, there is some time which is required for the buildup of toxic material whenever there is an enzyme or a cofactor deficiency, and that's why we always see a period of normalcy followed by sudden deterioration. And this is more for the acute intoxication related disorders. And then catabolic triggers. So whenever the child was well, but then suddenly because of fasting or because of some diet or because of some minor infection, there is a rapid progression of symptoms, then we have to suspect an IEM. And for reasons which I have told before, sepsis-like symptoms, but always IEM has to be considered there. And when there is for unknown cause, there is a very rapidly progressing encephalopathy, suspect IEM. And when there is a family history or a peculiar order, which we generally miss in very busy intensive care units, but then we should have to always think about that, any peculiar order and intractable hiccups. So while occasional hiccups are quite common, but when intractable, which simply means that your brainstem respiratory arc is disturbed by some toxic metabolites causing these intractable hiccups. And then when there is associated multi-system involvement, especially organomegaly, are these conditions where you really have to suspect an inborn errors of metabolism. So once we suspect these groups of disorders, we really don't have time to wait for the final test. So a simple test, just like how you send sepsis screen and hemogram LFT, you also have to send first-line metabolic investigations. That is a ideal way to actually pick up these disorders very early. So for example, we call it by the mnemonic GELAC, which stands for glucose, then blood gas, lactate, ammonia, and ketones. So a little bit about these. So normally there is no real definition for hypoglycemia, but then in a very young neonate, we keep it as the blood sugar level should be at least more than 50, and for older neonate, more day 3 or older, at least should be more than 70. So as far as neonates is concerned, I think there is no universal definition. Any sugar level where there is onset of symptoms should be considered as hypoglycemia. And then similarly, in metabolic disorders, we always get a high anion gap metabolic acidosis because of accumulation of toxic acids, fixed anions. But sometimes when there is associated tubular dysfunction and loss of bicarbonate, we can get normal anion gap metabolic acidosis. As far as lactate and ammonia is concerned, the most common reason for elevation is spurious. It's a pre-analytical error. So we have to really make sure that it is a free-flowing bed and immediately transported in specific vials, and has to be transported on ice or ice water, and has to be analyzed as early as possible. And then coming to ketones, newborn blood do have some amount of ketones, but we know that in a basal state, ketones are the major source of energy for brain. So which simply means in conditions like fasting, in normal conditions, the ketones will never exceed the threshold of renal threshold for its excretion. So which means any amount of ketone in the urine in newborn is definitely abnormal. So having sent these first line investigations, and if you get some alarming signs, it is equally important for us to send the second line confirmatory testing like TMS or urine GCMS, but then we have to immediately start the treatment. So the supportive care is you people to you can really do that well, and it's important that that always has to be taken care of. But then some management, importance of management, which differs quite from the conventional management of other non-IEM disorders, is what I'm going to talk about. So most important is catabolism. So what happens is the more the body is going to break the complex molecules, then there is, and with enzyme deficiency, there is going to be buildup of toxic materials. So it's important that we prevent catabolism. So that should be a first step. We keep the child NPO, baby NPO, so that no further precursors causing those toxic metabolite buildups are given. And we always prefer oral route if it is a mildly affected neonate, but then if it is a severely affected, then of course we have to give an IV route. But in both, we have to really make sure that provided there are no other fluid overload issues, then we have to give a higher level of maintenance fluid, correct the dehydration if present, and give higher, at least 1.2 times the maintenance fluid. And we give a simple sugar like dextrose. And the reason is because we know that dextrose will stimulate insulin release, and insulin is an anabolic hormone. So anabolism is, of course, definitely going to prevent catabolism. But then at the same time, we have to make sure that there is no protein restriction beyond 48, but the current guidelines even says beyond 24 hours, we should not restrict, because the more we're going to restrict, the body is going to break down its own fat and protein, and which is going to, in fact, cause the scenario even more severe. So we try to restart protein as early as possible at a minimal amount and see how the baby is responding. If not able to give orally, then we can give this amino acid, special amino acid mixtures, IV, but then we do have to, and IV lipids for energy, but this we have to restart as early as possible once the child is stabilized. As far as acidosis is concerned, generally the correction is not required. We say because most of the time when we address the underlying problem and we prevent catabolism by providing adequate hydration, the acidosis gets corrected. Nevertheless, if the pH is really very low, like less than 7, or bicarb is really low, then we can give a half correction. But then more than that, if the condition continues to worsen, it's better to go for dialysis. And as far as hypoglycemia is concerned, the most important part for managing hypoglycemia in IEM is you should never reduce the glucose concentration if there is hyperglycemia. So you'd start with dextrose and then try to maintain the GIR minimum at least 8 in neonates. But then if the glucose shoots up, then we try to give insulin to stabilize or to normalize the glucose level, but never we should reduce the glucose level, because that is a source of energy and that is a source which prevents catabolism in these neonates. And as far as hyperammonemia is concerned, we use certain nitrogen scavenging agents. So amongst this group, benzoate is IV forms are not available in India. So we try to use oral through NG tubes. So we have sodium benzoate, L-arginine is available. Phenyl butyrate acetate is recently available, but then it's a bit costlier. And in very severe cases, when the ammonia level is really high, then we have to start the dialysis and we have to keep a low threshold for that. And since we really don't know what disorder we are treating, so we can give a multivitamin therapy empirically, because it's anyways not going to be it's not going to be toxic. It's a low toxic therapy. And carnitine is one, especially for when there is a secondary carnitine deficiency, but we empirically do start, except when we suspect few groups of disorders, which we will discuss in the upcoming cases. Otherwise, we try to give IV or oral or through NG tube, because they will help in eliminating the toxic metabolites by conjugating with them. So in short, when compared to the conventional therapies, what we really have to do is we have to send the critical sample before starting, as if possible, but then stop the catabolism immediately, provide adequate calories in the form of lipids, and later after 24 hours or 48 hours start protein, and treat hyperammonemia aggressively. Keep a very low threshold for initiating dialysis in case of severe hyperammonemia or acidosis, and start cofactors as they are low toxicity in nature. But then we should never reduce the glucose infusion due to hyperglycemia. Instead, we have to use insulin, and don't continue the restriction of protein beyond 24 hours, and don't miss the dialysis window. And very important is don't consider everything as sepsis, especially when you find atypical findings. So with this basics, because even before the diagnosis is made, sending GELAC investigation and then suspecting an IEM, and then this empirical management has to be started before your TMS, GCMS report arrives. So with that, I move on to this few interesting cases where we have learned about what we have learned about acute IEM. So this is a 4-day-old male with uneventful antenatal birth history. Again, as you can see, more or less all these cases will have non-specific symptoms like had loose stools, had poor feeding, and then on examination was lethargic, dehydrated, and had mild hepatomegaly. And glucose, spot glucose was checked by a capillary method and was found to be low. So when you look into the family history, even in a busy ICU setup, never ever forget to take a family history, because here we can see that though they are very unrelated, looks like unrelated, there are two sibling deaths, so they have no live issue. One male expired, one female expired due to different causes, but we really don't know they are interlinked or not. But then as I told you before, with sepsis screen, always send GELAC, as you can see here. But what we find is there is hypoglycemia, there is some electrolyte abnormality, lactate is really high, and there is severe metabolic, high anion gap metabolic acidosis, and positive ketones. Whereas ammonia or ammonia is normal and urine NGRS is negative. So this is quite expected in a case of acute gastroenteritis or an accompanying sepsis, though the screen is negative. So we have to start the conventional treatment, which was started in this child, who he required ventilation, and then hypoglycemia was treated with bolus, followed by GIR of up to 8, and empirical antibiotics was started. But then what happened was his sugar normalized, but then his encephalopathy really did not improve. So this is where it has to strike that maybe all these underlying metabolic abnormalities are not truly due to only due to gastroenteritis. So what the clues or the red flags for suspecting an IEM? So there is a period of normalcy. So 4-day-old was fine first 3 days, and there is a positive family history, though it is non-specific, so we really don't know. But there is a negative sepsis screen, at least at onset. But there is hepatomegaly. There is mild hepatomegaly, but then this again is quite unusual in this setting. And most important is there is a disproportionate severity. For a 1-day history of loose stool, poor feeding, we can see that the lactate and the acidosis are really quite high. And despite sugars normalizing, there is no improvement in his sensorium. So these are the real red flags which makes us think that he might be having an underlying inborn errors of metabolism. So here again, the main metabolic abnormality is hypoglycemia. So what we can see is a little bit about this hypoglycemia. So we know that when the body is compensatory mechanism, that whenever insulin falls, whenever there is hypoglycemia, the insulin goes down, and then the counter-regulatory hormones increases, and all this plays an important role to maintain euglycemia. And so this graph shows that all of these happens in a very graded manner. So initially, the first body's defense mechanism is glycogenolysis to maintain the sugar level, followed by gluconeogenesis, lastly by fatty acid oxidation and ketogenesis. So this flow will really tell us the window, the how much amount of fasting has triggered hypoglycemia. Based on that, it will give us clue. But then it is quite difficult really in neonates because of their low physiological reserves. So as I told before, just like for older children, we have this Whipple's triad for defining hypoglycemia, but then in neonates it's quite difficult to say. So when the plasma glucose is low enough to cause signs and symptoms of brain dysfunction, we should consider it as hypoglycemia. So at a level below generally 70, we start getting these neurogenic sympathetic responses. So there is jitteriness, there is irritability, there is tachycardia, and it's important that we intervene at this level, because beyond 50 or there occurs a stage where there is neuroglycopenic symptoms, where the child will have bradycardia, lethargy, coma, and that is quite really dangerous. So, and hypoglycemia per se can be due to either metabolic or hormonal causes. So if we just look from a clinical approach point of view, this kid had hypoglycemia, there's NGRS is negative, urine ketones were high, and there was mild hepatomegaly, and when we did plasma lactate, it was increased. So here we can see the differentials which are there are glycogen storage disorder type 1, fructose 1,6 bisphosphatase deficiency. But then GSD, it's quite rare to present in such in a 4-day-old neonate. It generally happens in first 2-3 months of life, and so one of the strongest differential we can consider here is fructose 1,6 bisphosphatase. So when the TMS GCMS result arrived, we can see that the GCMS, apart from showing raised lactate and ketones, there is also elevated glycerol and glycerol 3 phosphate. So what exactly they mean? So even before getting a genetic testing done, what we can understand is such analytes can be seen in this fructose 1,6-bisphosphatase deficiency, an enzyme which is involved in the gluconeogenic pathway. So gluconeogenic is formation of glucose from non-glucogenic substrates like your proteins or fats or aminogenic amino acids basically. So here what we can see is whenever there is a block, there is no production of glucose. Instead, all these downstream analytes like your glycerol, then your lactate, all these gets elevated. So that's what we see here in this patient, which we confirmed it later through an exome sequencing, which identified a compound heterozygous, likely pathogenic mutation. And this turned out to be fructose 1,6-bisphosphatase deficiency. So this is a disorder which can be quite catastrophic, but then once diagnosed, is relatively easy to manage because they this neonate was initially asked just to avoid hypoglycemia. So that can be done by frequent feeding. But later, when this kid grew and started taking solids, and then the night fasting window increased, we put him on uncooked cornstarch after, mostly after 1 year of age, especially the nocturnal to avoid nocturnal hypoglycemia. And we do have to restrict certain food containing fructose, sucrose, or sorbitol because we saw that these are the precursors for this gluconeogenesis. So we also give them the family this kind of sick chart because every time it's difficult for them to travel so far. And when this kid was so fond of fruits, so we have to again give a restriction because most of the fruits contain fructose, sucrose. So we have to give them a list about which fruits really needs to be controlled. And currently he's on follow for quite a long time. He's 8 years old right now with normal growth and development. Intellect is also normal, but then because of initial prolonged ventilation, suspicion of IEM was done a bit late. So he had a tracheostomy done, and so because of that, he has some phonological issues. But then there are multiple admissions, especially during intercurrent illnesses when his food intake really comes down. So they keep a very low threshold for admission. So he gets admitted only during those intercurrent illnesses, and otherwise he's doing good now. So moving on to the second case. So this is a 36-week-old late preterm. Was born by emergency LSCS because of CPD. Birth weight we can see for 36 week, it is more than 97 centile. And 2 hours of life. So within first 2 hours, the child had poor feeding, lethargy, and was found to have hypoglycemia. So family history, you can see that there was another baby who was born macrosomic, had birth weight of 4 kg, but then she succumbed during her early in late infancy period due to some intercurrent illness. So this kid was started on emergency hypoglycemic protocol, and where the GIR went up to 12, but then hypoglycemia still persisted. So the GELAC investigation we can see is relatively normal. There is just hypoglycemia, which is quite severe. So always it's important that when we encounter a case of hypoglycemia, along with GELAC, though this is purely an IEM this thing, but then we should also think about another condition which very commonly presents with hypoglycemia. So we have to send the critical samples for insulin, other counter-regulatory hormones. And what we can see is for such a degree of hypoglycemia, the insulin level is really very high, and the free fatty acid and the ketone bodies are really low. So this is almost like a state of hypoketotic hypoglycemia. And the counter-regulatory hormones is inappropriately low. So ideally, it has to be very high for hypoglycemia, but we can see that this is not that high. So again, the clues for suspecting metabolic disorder here is a very early onset. So generally we say 2 days, 3 days window, but then here within 2 hours of life, there is severe hypoglycemia, and this is the LGA baby where we really have to think about insulin as a causative factor, and there is no response to very high GIR and positive family history. So again, if we look into this chart, the NGRS is negative, urine ketones low in a hypoketotic hypoglycemia. Without any other GELAC metabolites elevation, think of hyperinsulinism. So this kid, we started her on diazoxide therapy. There was no response. Then octreotide and tablets, sirolimus, everything was started by the endocrine department here. But then she continued to have hypoglycemic episodes. And meanwhile, we know that congenital hyperinsulinemia of infancy, majority are caused by their 2 genes, KCNJ11 and ABCC8. So we identified a heterozygous missense, likely pathogenic mutation, but this was inherited from an asymptomatic father. So this again, whenever in the CHI case, which is refractory to medical treatment, and it is inherited from one of the asymptomatic parent, and there is no other second mutation, especially coming from asymptomatic father, we have to think of the underlying pathophysiology to be a focal cause. So what exactly happens is this ABCC8 KCNJ11 lies in this 11th chromosome, where there are also imprinting genes nearby. So in a normal, think of the normal pancreas. So there is one germline mutation coming from the father, but then in the focal region, if there is a second hit, just like your retinoblastoma, if you would have thought at the somatic level, so at the tissue level, if there is a second hit, then there'll be this imprinting genes goes haywire, and that will cause a focal hyperplasia of the pancreatic cells. So this is what has to be assumed, and then we, in such cases, have to go and do a DOPA PET to identify any focal tumor. So this kid had a focal tumor in the uncinate process, which was secreting inappropriately the insulin. And why it is important? Because in CHI, diffuse CHI, the treatment, medically refractive cases, the treatment is total pancreatectomy, which is quite hazardous in the long run. But then when we identify such a cause, we can go for a focal pancreatectomy, which is relatively a better, which has a relatively better outcome. But then at 2 years of age, this kid had gastroenteritis and succumbed to the illness. We could not save her. But then the lesson from this case is that whenever hypoketotic hypoglycemia with normal GELAC parameters presenting as early as the first day of life, always think about congenital insulinism of infancy, and majority of which are caused by this ABCC8 and KCNJ11. And especially if you get a monoallelic mutation coming from the father, think of this focal pancreatic lesion as the cause for hyperinsulinism. So next case, so this is a 28-day-old child, so quite old, a late neonate. So this is had fever, again non-specific symptoms, altered sensorium, circulatory failure, mechanically ventilated, required IV fluid, anti-epileptics, antibiotics, etc. And on workup, sepsis screen was negative. So again, there is a significant family history. And when we looked into the GELAC, what we found was there is hypoglycemia with a high anion gap metabolic acidosis. But in addition, we also saw that ammonia level was really very high, but there is no urine ketones. So this kid was started again on with the suspicion of IEM, high increased maintenance fluid, and then hypoglycemia, required a GIR up to 10 for management, and metabolic acidosis, half correction was given. And the child, because ammonia was too high, required dialysis as well as scavenging agents. So by the time when the TMS, GCMS report came, what we found was that the TMS showed an increased C5OH level, which is a marker for leucine degradation or for biotin recycling defects. So we also did a biotinidase assay, which was normal. And then urine GCMS showed these analytes, these complex analytes, but these are metabolites of leucine degradation. Now, coming back to the case, this is hypoglycemia, but with acidosis and hyperammonemia. So if you have to again really put into the table, this is again hypoketotic hypoglycemia. So that is what most important. Previous case, we saw that this without acidosis or without other findings, we should think of hyperinsulinism. But here we have acidosis, we do have hyperammonemia. And so there are two differentials left, fatty acid oxidation or ketogenesis defect. But then what about this leucine? So what these metabolites are doing here? So for that, we should understand the pathway, because there is one particular enzyme called HMG-CoA lyase. This is an enzyme which is involved in the synthesis of ketone bodies. So as we can see here, the ketone bodies are synthesized either through fatty acid oxidation or through this leucine degradation. But when there is a block in this enzyme, all these the preceding analytes gets increased in the urine. Because of that, we have this leucine metabolites in the urine, and also because there is despite fatty acid oxidation, there is no production of ketone bodies, which causes hypoketotic hypoglycemia. So here the problem is not just hypoglycemia, it's also these toxic metabolites, which can suppress the urea cycle disorder and can cause hyperammonemia. So this we confirmed through molecular testing, but then when we did the NGS, we identified just a single variant for an autosomal recessive disorder, which is a pathogenic variant, getting inherited from an asymptomatic mother. But then we know that biochemically this is a case of HMG-CoA lyase deficiency. So we went ahead and did other alternative molecular techniques to identify the second large deletion involving exon 2 of HMG-CL. So, and this was again found to be inherited from asymptomatic father. So this sometimes the reverse really helps when we have a very strong that is the beauty of IEM. So when we have a strong biochemical suspicion, even if the final sequencing do not yield desired result, then we can really pursue and find out the underlying cause, like what we saw in this particular case. And so we went ahead, and this kid was somehow came out of the acute crisis, and she was put on moderate protein restriction. So not entire protein generally is not required. It's just to limit the leucine. So we started her on this leucine-free special diet, and fat was restricted to just mild extent, 25% of energy. So this kid was again given a diet chart, which was frequently revised by our dietitian. So we always give them this kind of list. And we can see that the parents were well educated. So that is more important because these kids have to be followed up long term. And we can see so many admissions for this kid, but none of these admissions she had metabolic crisis except for these two, because this to just show that the parents were so vigilant that even with the start of metabolic intercurrent illness, and if her feeding goes down, they immediately take her and admit her, and we start the treatment just to prevent a metabolic crisis. And subsequently, this child is currently 6 years old with a good growth and development, and managed simply on diets, and really doing well. So next case is a 4-day-old infant. Again, we can see non-specific symptoms, but then this is an encephalopathic infant. But then what we can see from this 3-generation pedigree, which almost clinches a diagnosis, is so many deaths of male siblings and also a maternal uncle. So this kind of pedigree will give us an idea of some X-linked disorder, which generally happens in males, is underlying cause for this IEM. So even before the initial set of investigations, we can make a diagnosis. But then the GELAC came, and what we can see is that the ammonia level was really sky high. Normally in newborns, it should be considered less than 100, but then here we saw that the level was really very high. And normally in an encephalopathic infant where we expect a metabolic acidosis, what we have seen in turn is respiratory alkalosis. So again, the red flags for IEM: period of normalcy, positive family history, negative sepsis screen. But most important is in the setting of encephalopathy, when you see respiratory alkalosis, you do have to rule out hyperammonemia, because that is one, because ammonia generally stimulates the respiratory center and causes tachypnea, leading to respiratory alkalosis. So little bit about what exactly this ammonia is. So we all know it's a byproduct of protein metabolism. It is a toxic waste product and generally gets detoxified by the liver. Some happens in the mitochondria, some happens in the cytoplasm of the periportal hepatocytes. And then the second mechanism, which happens in brain or skeletal muscle, is through glutamine synthesis. So glutamate by glutamate synthetase traps all this ammonia and then converts it into a non-toxic product, which will eventually get eliminated by the kidneys. And important, this cycle is really very important because we know that ammonia is a toxic product, so neurotoxin, which can cross the blood-brain barrier and causes neurological symptoms. So the early symptoms can be poor feeding, lethargy, but then later CNS predominant symptoms can be seen in these individuals. So from metabolic point of view, ammonia can be of two types. When there is a primary defect in the enzymes involved in urea cycle, we call it as a urea cycle disorder. Primary hyperammonemia. Or related to the transporters involved in the urea cycle disorder. But then if the defect is outside the urea cycle, but then it indirectly affects the urea cycle function or inhibits some of its substrates, as we saw in the previous case in the ketogenesis disorder, where the toxic metabolites from leucine has impaired the urea cycle. We call it as secondary hyperammonemia. And this is the reason why apart from urea cycle disorders, in organic acidemias and few aminoacidopathies, we get hyperammonemia. So this again, a very busy flow chart, but then what we have to remember is there are even non-IEM causes like liver failure, valproate, which can inhibit some of these substrates or enzymes and cause hyperammonemia. So whenever we blood ammonia levels are very high, what we have to do is look at the ABG. If there is no acidosis, no ketosis, think of urea cycle disorders. On the other hand, if there is acidosis or ketosis, then the differentials will point towards secondary hyperammonemia causes. So once it is an isolated hyperammonemia, then we can look into specific amino acid elevation by the TMS. So especially in a distal block, when the block is distal, the precursor and precursor substrates get elevated, and based on that we can identify the disorders. But if there is no specific amino acid elevation, then it is important that we look at the orotic acid. So what is orotic acid? Basically, in this proximal urea cycle, this, or whenever there is this ornithine transcarbamylase deficiency, there will be buildup of carbamyl phosphate, and this carbamyl phosphate gets converted into orotic acid. On the other hand, if the defect is at the CPS level, then there will be no orotic acid excretion in the urine, and that's how we distinguish between OTC deficiency and CPS deficiency. So here in this patient had a low citrulline arginine level, so the downstream metabolites were low, and the urine GCMS showed elevated orotic acid levels. So even without performing a genetic test, we can confirm, and with the family history background, we can confirm that this to be a case of ornithine transcarbamylase deficiency. So this kid was kept nil per oral, and and was managed again to prevent catabolism and to promote anabolism. We had given glucose, and then ammonia scavenging agents were used. But then when the ammonia level is really very high, we do have to keep a low threshold and start on dialysis as early as possible. But then the scavenging agents, how they really work, they just trap the nitrogen ions. So we can see that benzoate by conjugating with glycine, and phenyl acetate by conjugating with glutamine, gets converted to these non-toxic products and get excreted in the urine. So this was the final diagnosis, was confirmed by even genetic testing. So this is next case, a 14-day-old female, again had similar specific symptoms. But then here what we saw was that there's no significant family history. And when we looked into the GELAC picture along with basic, we see that the sepsis screen was positive. Blood culture showed Staph aureus, and there was neutropenia and thrombocytopenia with transaminitis, with elevated lactate and high anion gap metabolic acidosis. So this is quite a classic picture for sepsis and sepsis-related severe sepsis. We can get such picture. So this kid was started on oxygen support. At the outset, there was no suspicion of IEM. So she was started on antibiotics and other supportive management. But then what happened was that despite standard treatment, there was worsening encephalopathy. So what we can see is that even the metabolic parameters worsened, the lactate increased, and then the ABG worsened, even more high uneven gap. Ammonia started rising, and then ketones we can see was very high. So this again should lead us to a suspicion of inborn error of metabolism. So when we look at a very high iron gap metabolic acidosis, we have to first see the lactate. But generally lactate, if it's elevated, we will think of mitochondrial disorders. But here there is also background of sepsis, so we really can't rule out this group of disorders. But then urine ketones were also present. But in addition, this neutropenia, thrombocytopenia can be seen in conditions like organic acidemias. So this kid was started on the appropriate acute management for IEM, and the TMS report arrived, which showed that the C3 levels, propionyl carnitine was elevated, and there was 65-fold elevation of methylmalonic aciduria and propionic acid. So what exactly it is? So these are the mechanisms by the pathway. What happens is that these are all the orchin fatty acid, propionic acids, and these are some of the amino acids which contributes to the propionyl CoA. But then eventually for the downstream conversion, we need these specific enzymes and cofactors which are necessary. But whenever there is a blockade, either in the mutase enzyme or in the vitamin B12, there will build up of methylmalonic acid and subsequent upstream metabolites. So this kid was started, after knowing this diagnosis, was started on IV hydroxycobalamin. And why it is needed? So we always give a trial of hydroxycobalamin here, because if the defect is in the vitamin B12, then they really respond well. And this kid was also started on metronidazole prophylaxis, because we know that significant amount of propionic acid comes from the gut flora, so we have to eliminate that. And then he was gradually introduced on low protein after 48 hours, which the child tolerated, and was started on MMA diet. And this was later confirmed to be a type A. This is a vitamin B12 responsive, which means the defect is not in this mutase enzyme, but is in the adenosyl cobalamin transporter defect. As a result of which, these kids really respond well to hydroxycobalamin. So this kit was subsequently followed up, and ideally, the hydroxycobalamin should be given in injectable form every day. But sometimes we can, based on the response to treatment by measuring the metabolites, we can alter it. So this kid is tolerating well on a weekly dose and on a MMA diet with metronidazole prophylaxis. This kid is really doing well now at 1 year of age. So the important lesson which I have learned from this case, and it is important for us to know, till now we saw that IEM is a sepsis mimicker, but sometimes both of them can coexist. In fact, the sepsis can trigger a crisis. On the other hand, IEM can cause sepsis. So this is a classic example, organic acidemias group, because the sepsis, by causing catabolism, there'll be an increased metabolic demand and waste, which can trigger an IEM crisis. On the other hand, in those inborn errors of metabolism can cause immune system dysfunction, like impaired WBCs and neutrophil dysfunction. And that is the reason this kid had neutropenia, thrombocytopenia, and they also can cause chronic stress and tissue damage, which in turn can increase the vulnerability to infection. So this is just a reciprocal amplification where sometimes sepsis and IEM can coexist, which simply means if the child has sepsis, but still again not behaving well for your good broad spectrum antibiotics, think of inborn errors of metabolism. So this is another case, child on day 6, refractory seizures, lethargy, coma, not responding to standard treatment. On a day 23 of life, they found the child had some degree of hyperammonemia and with not a very significant family history. There is one SIDS history, but we really don't know the cause. And consanguinity is there, but otherwise there is no significant history. And then when we examined this child for the severe degree of encephalopathy, the tone was really normal. And there was some peculiar order, but however, the sepsis screen and the GELAC was completely normal. But then here, what made us think about an IEM was this peculiar order and also this normal tone. So normally, encephalopathic kid, other causes other than IEM, generally the tone will be hypotonic. But then if we see a normal tone in encephalopathic kid, that means there is relative hypertonia. So that kind of picture we generally get in a metabolic encephalopathy, and that's what made us suspect an IEM. And when we did TMS, GCMS, this showed elevated branch chain amino acid and alloisoleucine. And the GCMS showed corresponding keto acids. So what exactly is this MSUD, which is maple syrup urine disease, is that when there is a deficiency in the enzyme branch chain alpha keto acid dehydrogenase. So this is a complex. There are multiple subunits and different genes code for different subunits. So any subunit when gets affected can cause MSUD. And this is mainly due to this 3 amino acid, leucine, isoleucine, valine. So when their breakdown is impaired by this particular deficiency of enzymes, there'll be buildup of all these alpha keto acids, which is going to cause the classic encephalopathy picture. So this kid again, with routine management, was also started on this BCAA free, that is branch chain amino acid free formula via OG tube, and the breast milk was just quantified. It was expressed and quantified. And it was given, and then a thiamine trial. Really, for classic MSUD, thiamine doesn't help, but it is a cofactor for this particular enzyme. But then there is no harm in giving the trial to see for the response. So this is next case, 3-day-old male. Again, non-specific symptoms, but this child, in addition to lethargy, had irregular heart rate and severe hypotonia and hepatomegaly. So there are almost multiple systems involved here. And when we looked into the GELAC picture, in addition to hypoglycemia, there was some amount of lactate elevation, but then ketone was absent. And ECG showed ventricular tachycardia and echo showed dilated cardiomyopathy. So again, the pointers here, period of normalcy, but there is cardiac involvement here for the first time. And in the cases which I've shown, and there is severe hypotonia with a negative sepsis screen, and there is hypoketotic hypoglycemia. So if you remember hypoketotic hypoglycemia, with acidosis, in the presence of acidosis or lactate elevation, there are two differentials, ketogenesis disorders and FAOD, fatty acid oxidation disorder. So here the TMS showed low free carnitine, but an elevated free fatty acid, a long chain, very long chain fatty acids. And GCMS showed a non-ketotic carboxylic aciduria, which gives us a diagnosis of very long chain fatty acid dehydrogenase deficiency. And here, of all the cases we see previously, here heart is predominantly involved in these kind of cases, because we know that at the basal fasting state, following glucose, the second most important metabolite for heart is your fatty acids. And that's why any defect in the fatty acid pathway can affect cardiac condition. So till now we saw CNS cases mostly presenting as encephalopathy, seizures, etc. But then this was another 7-day-old child who had hyperbilirubinemia and was given phototherapy in an outside hospital. But then on day 7 of life, despite phototherapy, the bilirubin worsened, had lethargy, poor feeding. By then the newborn screening result came, which showed the total galactose to be positive. But then this is a screening test, so we always need confirmation before proceeding with treatment. So on examination, this child had hepatomegaly, and GELAC showed an acute liver failure kind of picture, but other GELAC parameters were normal, and the fundus showed oil drop cataract. So we did, this leads us to clinical suspicion of galactosemia. So we did a fluorometric based quantitative galt assay twice, and both the time it was below the detectable limits. So this kid, breastfeeding was stopped. One of the very few conditions where breastfeeding, in fact, breast milk is contraindicated, and this kid was started on a lactose-free diet, responded beautifully well. So we could taper the anti-epileptic drugs, and this was also confirmed by sequencing test. And currently this child is on lactose-free diet and who compliant and 3 years old now. And the cataract, in fact, there was a spontaneous resolution. So through these cases, what I would like to convey is always consider a treatable disorder, send simultaneously GELAC investigations, but then don't wait for the report, start empirical treatment immediately. And we, in an encephalopathic child, we have to suspect a metabolic disorder, especially if you see a normal peripheral muscle tone, or you see contradictory. There is an axial hypotonia with limb hypotonia, or intractable hiccups or myoclonic jerks, or abnormal order. Always think of metabolic causes. If you see a predominant ketoacidotic picture, we can think of maple syrup urine disease. Of course, maple syrup urine disease can be with normal GELAC presentation also. And when you see, in addition to ketoacidosis, bone marrow suppression picture, think of organic acidemias. When the lactate level is predominantly the striking metabolite abnormality, think of mitochondrial or fatty acid oxidation disorders. When there is isolated hyperammonemia, think of urea-cycle disorders. And when there is normal GELAC, again MSUD, but non-ketotic hypoglycemia is one of the condition. And if you see predominant refractory seizures, this is also another common case. So I have not shown a case, but then this we can suspect pyridoxine responsive seizures or folinic acid responsive seizures. When there is severe hypotonia, so think of fatty acid oxidation disorders or carnitine transporter defects. When there is liver involvement, especially presenting as acute liver failure, think of tyrosinemia. The list is quite exhaustive, but I'm just enlisting very common disorders which we see. So for liver failure, galactosemia. When there is hepatomegaly with hypoglycemia, think of hyperinsulinism or fructose bisphosphate or GSD. When there is cholestatic jaundice, think of alpha-1 antitrypsin, bile acid metabolism defects. And when there is heart involvement, specifically think of fatty acid oxidation disorders or respiratory chain disorders. So this is more about acute IEMs in a sick child, and a little bit about complex molecule disorders, because they are also inborn errors of metabolism and few of them are treatable. So it's important for us to know. But nevertheless, the symptoms will be present from birth, and most of them will have some kind of skeletal or dysmorphic features, and they also can have organomegaly. Like for this child who was on day 10, a floppy child, a severely floppy child with normal GELAC investigation, and on X-ray found to have cardiomegaly with short PR interval, large QRS complexes, echo showing HOCM. So there is a very straightforward diagnosis of Pompe disease, which we can confirm by enzyme analysis, the acid glucosidase enzyme, and by molecular testing. And recognizing such cases are important because Pompe disease, though it's a storage complex disorder, it is treatable. We have enzyme replacement therapy, and the earlier we detect, the earlier we start, the response is better. And this is another case which I saw in our department in a neonatology unit, an 8-day-old male, where antenatal USG showed non-immune high drops. And the course was quite catastrophic, had a lot of sepsis and coagulopathy and septic shock. So we can see from the face that the child is appearing a bit coarse. And here, USG showed hepatosplenomegaly, and infantogram, in fact, showed, I don't know if it's quite evident, but we saw the small punctate lesions in the epiphyseal region of long bones, suggestive of chondrodysplasia punctata, and this turned out to be galactosialoidosis. And we could make this diagnosis because though this child had a very catastrophic a down course, but then the neonatologist saved the blood sample, and this child expired, unfortunately. But then from the stored sample, we did the exome testing and identified this particular disorder, which is very, very important, at least for the family, because for reproductive counseling and subsequent prenatal testing. So while till now we saw what happens when we don't diagnose IEMs on time, but sometimes when we overdiagnose, that also cost us a lot. So like this case, which it was referred when the child was 6 years old to us, but then this kid was had some sepsis-like picture in the neonatal period, had hypoglycemia, ketoacidosis, and TMS showed branch chain acid elevation, but then the exome sequencing was negative. But this kid was somehow labeled as MSUD, and he was put on MSUD diet, maple syrup urine disease. But then in between, he developed severe skin lesions in the form of acrodermatitis enteropathica, which generally happens with MSUD diet because of this isoleucine deficiency, which we restrict. They can have such kind of skin picture. And then, so the parents stopped the diet, and he was just put on a lifelong protein restricted diet. So when this child came to us, his growth was nearly, it was a third centile. And but when we reviewed the records and examined, he really, despite this half treatment, he didn't have any metabolic crisis. His intellect was normal. And when we repeated the metabolic markers and we also did an exome reanalysis, it was completely normal. So this was a child who was falsely labeled as MSUD, and for unknown reasons didn't follow up properly or followed up somewhere else. And the most probably the reason why he was labeled as this BCAA is because this kind of elevation can also be seen in non-IEM conditions, especially in catabolic states. Catabolic states, we can see branch in elevation, and TMS, and the important marker for MSUD is alloisoleucine, and TMS cannot distinguish between leucine or alloisoleucine, and maybe that's the reason this was wrongly labeled as a case of MSUD. And this is another child whom we saw again sepsis. TMS showed raised C3, and GCMS showed mild elevation of MMA, and this child was labeled as MMA and was put on the MMA diet, and then was referred to us at 6 months. But then till 6 months, there was no crisis, and genetic testing was negative. We couldn't find any variant related to MMA. And when we repeated the TMS urine GCMS at that point of time, it was normal. But then generally, even on a very good diet, this complete normalization of metabolites really doesn't happen when there is a true IEM disorder. Then when we further worked up, we found that the maternal B12 level was low and her urine MMA was elevated. So here, the MMA elevation was secondary to maternal vitamin B12 deficiency. So it is important for us to know that not all, because these metabolites generally reflect not just inborn errors of metabolism, but more commonly it reflects all other metabolic non-inherited metabolic abnormalities which can happen when a child is sick. So these are some of the commonest conditions where we can see the markers elevated, but most of the time it is due to liver failure or kidney failure or use of certain drugs or sepsis, which are contributing to the elevation of these markers. So it's always important that while we have to treat this as early as possible, but then we should really not over treat it, or even if we treat it, we have to refer the patient to expert who can follow up these kids and make correct diagnosis. So to conclude, the overall conclusion which I would like to propose is think sepsis and IEM together, not sepsis followed by inborn errors of metabolism. And always think about the commonest causes. So avoid the trap of over treatment. So always there can be millions of reasons for transient elevation. So you have to do a clinical correlation. And in this, especially newborn screening era, we do get a lot of such analyte abnormalities in a relatively asymptomatic babies. So it's important that whenever you're in doubt, you always contact a metabolic expert and try to manage the case. Thank you so much.
Thank you. Thank you so much, Dr. Hasina, for that very insightful and well structured presentation. You have made a complex topic much easier to understand with your clear and practical approach. I really thank you for that. As I can see, we have a question in the Q&A section. It has been asked by Dr. Apeksha, like what difference a newborn screening genetic test done at early stage do to the treatment with child not showing symptoms. So I feel basically she wants to know advantage of a newborn screening for IMs, how it is going to help the treatment if the child is not having any symptoms. I will require your opinion as well as Dr. Madhulika ma'am. I also request your opinion on this question. Thank you.
Ma'am, you want to say?
Hasina, go ahead, please.
Yeah. So, very important in this newborn screening era. We that was my last slide. So, what I've told is the early we get these analyte abnormalities, it's very important that TMS. What we have to know is TMS is just a screening test, right? And there are a lot of other factors which can contribute to this analyte elevation. So, first we have to see under what setup the samples were taken, and it's always not wrong to start the babies on treatment, but then it is always important that we confirm it by a secondary method, either by doing a repeat TMS or a GCMS, and sometimes even by exome testing to do a confirmation. And another issue is majority of these, like the newborn screening, like various countries whom they're doing it for a long time, there are a lot of asymptomatic babies. So when they're followed up for a long time, especially conditions like this medium chain acyl dehydrogenase. So such babies really do well even without treatment. So we really don't know which Pandora's box here we will be opening with this newborn screening. But then what I would suggest is it's nothing wrong in starting the treatment, but then you refer to an expert who can follow up these babies and then can alter or taper the treatment accordingly.
Right.
Madam, your views on the newborn screening of IMs, ma'am.
So, as Hasina said, like I mean, these tender mass results are at times very confusing. You may have multiple metabolites which are elevated or abnormal, and then you may at times you may not be able to correlate it. Suppose it is looking like on TMS screening, it is looking like organic acidemia, but the baby doesn't have other manifestations. So I think a repeat sample would definitely be required, and we do the ancillary investigations. And as Hasina said, that if the child is totally asymptomatic, then I mean, putting him or her on a specific dietary therapy would also be difficult. So these are situations where we really need to confirm it by molecular testing, and follow up these babies is extremely important. So as Hasina said, MCAT, there is another disease, biotinidase deficiency, particularly in our country. In the Ummeed program, maybe Hasina also knows that we have identified many babies with biotinidase deficiency, and they are totally asymptomatic babies. And what we did was that we started all of them on biotinidase because that's easy and not very cumbersome to take, and then tried to confirm by molecular studies. So some of them have got some mild mutations, and it is known that biotinidase deficiency, if detected in the newborn period, they may not present in the newborn period in the classical phenotype, but they may present later on with some other phenotypes like skin or hair or other milder phenotypes. So we have to keep this in mind. And as Hasina said, this is a complex area. When you screen, then management at times becomes difficult. Particularly, she did not talk of, because my complex disorders, she did not talk of this, comes more into picture when we are screening for complex molecule disorders. And there, if there is a deficiency, should we start enzyme replacement therapy or no? Because we really don't know how the child is going to behave in a severe form or in a milder form, where we may wait for treatment. So these are the areas where really we need to explore more.
Thank you,
And
ma'am.
hmm.
We have certain more questions in the chat box. Dr. Shija Shapru has asked, basically regarding to lactate pyruvate ratio, and how does the alteration help in the diagnosis of disorders of pyruvate metabolism?
Hasina, you want to comment?
Yes, ma'am. This lactate pyruvate ratio first is not, I mean, we don't routinely do here because though lactate is available, this pyruvate measurement technique is not available everywhere. But then theoretically speaking, normally the ratios will be around 10 to 20. And when the ratio is less than 10, we can suspect pyruvate dehydrogenase kind of disorders where the ratios will be low. But then if the ratios are really high, then we have to think about conditions where the lactate is really high, like respiratory chain disorders or pyruvate carboxylase deficiencies.
Mm. But the pyruvate estimation is quite tricky. That's another issue because interlab differences are there. So pyruvate estimation is difficult doing it. But then, as Hasina said, it's sort of useful for classifying these disorders. So one thing which I would just like to mention here, that if you are suspecting an acute IEM before starting therapy, because as Hasina said, we have to start empiric therapy, please keep sample for TMS and urine. These are really precious samples because we are going to lose the diagnosis if we do not keep samples. So before you initiate treatment in the acute phase, as soon as the child comes, you maybe, if required, put in a catheter or take a suprapubic sample. Urine sample has to be stored and blood spot has to be taken. If possible, blood spot is there, you can do DNA also from that, or maybe save some EDTA sample, maybe some enzymes or something is required. So that's one important message which we need to give.
There is one more
Mayank, can
question.
I just come in for a moment? This is Dr. Seema Kapoor.
Thank you, ma'am. Thank you, ma'am, for joining.
Yeah. So I was proud to listen to Hasina speak on IEMs. So there are a little bit tricky things which probably we need to understand. The last question was the LP ratio, and in pyruvate dehydrogenase deficiency, you may not get a high citrulline. While in pyruvate carboxylase deficiency, where you do not have estimation for the basic pyruvate, think of pyruvate carboxylase effect. So, a tandem mass with a secondary analyte like citrulline can give you an answer between dehydrogenase deficiency and carboxylase deficiency. Secondly, many of these second tier tests, like alloisoleucine, are now available on the newer kits for detection. And also, a very important message is that whenever you do a tandem mass, the sensitivity is 98%. The positive predictive value of mass spec, even with ratios, secondary analytes, is just about 50%. That's why you have to understand that TMS is quite a screening test and it's really important. Otherwise, I think Hasina must have an excellent collection and very well done.
Thank you.
Thank you, ma'am. We have certain more questions basically related to uh, when to send ammonia level when the baby is on feeds or when the baby is sick and kept NPO. Dr. Hasina?
So as soon as the baby comes, if the child is really sick, we have to send these samples. But preferably, we say it's before feeds. But then we hardly face such situations in clinical practice. So as and when the child comes, it has to be sent.
Yeah, okay. So, if the baby is on antibiotics, are there any contraindications or limitations for sending NBS?
No, it's not a contraindication for sending NBS, but then again, antibiotics can interfere with the TMS report. Like well known is this pivalil containing antibiotics. This is what we read theoretically, but I haven't seen any case. But that can cause a false elevation of C5 levels. So that we have to keep in mind. But then that is not a contraindication per se.
Yeah, and then there is one more question regarding the frequency of sending the GLAC test. Suppose if it is normal and if you are suspecting an inborn error of metabolism, so is there any particular protocol we follow?
So not like, for example, I showed you this MSUD. And main thing is if the child is inborn and then you're very sure it's okay. But when there is no response to standard treatment, then always it is important that we repeat such test and look for it.
Thank you for that. I don't think there are any pending questions. So I would like some concluding remarks from our special guest, Dr. Madhulika ma'am, and as well as Dr. Lalan Bharti sir and Dr. Shima Kapoor ma'am.
Seema, you can start.
So I think it was an excellent presentation. And the most important thing is that the mitochondrial disorders, which may cause secondary hyperammonemia, do not come up on. See, there are 400 genes for mitochondrial dysfunction, and one of the commonest presentation is with hyperammonemia, which is secondary, not as high as about 800 to 1000. I think even the level of ammonia at the initiating point may give you a suspicion to uh, a disorder which is either urea cycle or mitochondrial. So hyperammonemias in secondary disorders are not higher than 800 to 1000. The moment you get 1000 plus, you're almost sure that this hyperammonemia is a UCD. That's and as Hasina has shown, the PUCD, the proximal UCD and the distal UCD. There are two important tests, orotic and citrulline. And these two itself will tell you whether it's a proximal urea cycle or a distal urea cycle defect. But that is too much important. So, what the only message is that citrulline is an important consideration in urea cycle defects. And yes, in NBS, you have a lot of maternal defects presenting. So, be very careful about those defects when you do not get anything on the exomes. I think that's what I would just like to add. And um, I would like to congratulate Dr. Madhulika and Dr. Hasina for an excellent overview.
So, Hasina, it was a wonderful talk. Very, very nice, very informative, very well structured, and messages very clearly given. And I don't know, Seema was there or not when I started saying that now, at least in Delhi government program, we have TMS also inbuilt, which is being led by Seema. So now it is all the more important that we identify these disorders in time, because and then treatment is possible under the rare disease policy. So these are two things which are there in the country, and it is very rewarding to identify these cases. And incidentally, I was reviewing. In fact, I was writing an editorial for an article in which a group of neurodegenerative, the babies who presented with neurodevelopmental degeneration, and a very high proportion actually turned out to be small molecule inborn errors of metabolism. So that clearly shows that we are missing these cases in newborn period and infancy, so that they reach to these sequelae. So I think it's extremely important to identify them, and the newborn people are the ones who should suspect it and pick them up early in the newborn period. I think it's extremely important. Thank you very much for having me here.
Thank you, ma'am. I feel the key takeaway from today's webinar will be early suspicion is critical in neonatal metabolic disorders. Non-specific symptoms should not delay consideration of IEMs. Timely intervention can significantly improve outcomes as shown by various case scenarios by Dr. Hasina. So I would also thank Dr. Hasina again. Sadly, our co-moderator, Dr. Rajesh, couldn't join due to some emergency. And I also thank all the participants for their active involvement. Topics like this remind us of the importance of continuous learning in neonatology as well as genetics. Thank you all for joining us today.
Thank you very much.
Thank
We
you.
look forward
Thank
to
you.
seeing you in future sessions of the NNF Genetics series. Have a great evening.
Thank you.
Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.